So as I said, this is the second PPIE webinar from Rare Disease Research UK, which is an initiative funded by the MRC and NIHR. There are 11 research nodes coordinated by a hub run from Newcastle, and I'm the PPIE lead for the hub. And what we do is try to promote the implementation of good PPIE within rare disease research. I am just going to share my screen so that hopefully you can see the lineup for today. So we have some great speakers for you today to talk about co-production, what it is, and their various experiences with co-production. After each speaker, we will have a time for a short Q&A, and hopefully we'll have some time at the end as well. So do hang on to your questions if you have thoughts while people are talking. First up, we will have Dr. Laura Cowley from the Rare Disease Research Network to give an overview of co-production and to talk about how it can play out in real life. Then we will have Allison Watson, who is the founder and chief exec of Ring 20 Research and Support UK. Our third speaker, Dr. Charlotte Tye, unfortunately is unwell, but she has very kindly produced a recording of her talk. So she'll be here in spirit, if not in person. And Claire Oliver, who is a PPIE contributor who has worked with Charlotte, is here with us today to talk about her experience. So Claire has a 10-year-old son with tuberous sclerosis he's non-verbal, he has autism and epilepsy, so he's significantly impacted by his rare condition. But it's very important to note that he's also very sweet and kind and cheeky. So I think we will begin. Laura, I will stop sharing to allow you to share your slides.
Brilliant. Thank you, everyone. Lovely to be here and share a little bit about what we've been doing. So I'm going to start with a really quick introduction to the PPI kind of national landscape. I know it's very crowded, but just to set the scene a little bit, and then talk more specifically about rare disease research, go into co-production, and then jump then into patient-led research hub, which is my day job, and introduce our new patient-led rare disease research network. So this might be a bit repetitive to some of you. I see lots of familiar names and faces, so it's lovely to have you on board again. Okay, so I'm sure this is no surprise to anyone, but I think the UK does PPI really well. There's a lot of brilliant initiatives, both at local and national level. And I think we are a world leader in a lot of regards. We've been doing it well for a very long time. So I just wanted to pull out two kind of very obvious things. And the first is the UK standards for public involvement. So that's the 6 kind of standards in that yellow box there. And they've been around for almost 10 years now, I think. But more recently, we've had the HRA and the NIHR release their shared commitment to public involvement. So this is really organizations sign up to this commitment to say that they will essentially follow these standards. But what I really like about it is that it highlights that lived experiences should be the key driver for health and social care research. So right away, we're getting at the need for co-production. But then I think what goes along with our enthusiasm for PPI is that we have this toolkit mountain. So a report from the Patient Experience Library in 2023 pulled out that we've got nearly 600 toolkits, which is obviously a bit overwhelming, and unsurprisingly, most of them are not actually used by anyone except for the people who wrote them. Sorry, if I just switched my screening. Does that still look okay?
We're back to presentation view.
I think what's interesting about this toolkit mountain is that most of them are published for investigators and PPI professionals trying to reach out to patient groups. And there's really not much out there for patient groups trying to reach out to investigators to get involved in upstream co-production and patient-initiated research. So why I think this is an essential, co-production is an essential tool within rare disease is because rare disease research is quite difficult. So there's few participants, there's few clinical experts, there's not very much funding or resource available. And I think a very sobering statistic is that less than 5% of rare diseases, and we think that there are probably close to 10,000 or more different rare diseases, and less than 5% have an effective FDA-approved treatment. So we really need to make sure that the research we are delivering can impact family and patient life. And unfortunately, within healthcare more broadly, we know that funded research still does not always focus on the questions and the priorities and outcome measures that are valued by the end users, so the patients and the healthcare providers. So it really is essential to get them involved in developing the research idea and designing the study. So I think we can safely say across the UK, research is patient-centered, but it is almost invariably investigator-led. And I think co-production is a great way that we can start changing that conversation. So co-production is a great solution because we get those end users involved from the very outset. So we're making sure that we're focusing on real world priorities. And in a very practical vein, this does really benefit your funding applications. So for the investigators online, you'll know that you need to weave in a compelling PPI plan throughout your funding application. And there are different ways that funders mandate patients and the public are involved. But I think we can really say that it will make your application more competitive. And then when we get down to research conduct, we know that if you've partnered meaningfully with a patient group throughout the process, then it does build trust with that patient community. You'll have a better network to promote your study to, and you'll probably see better recruitment and adherence, definitely within the rare disease community, I think. So it does have real benefit and real value. So what actually is co-production? There are lots of language that says similar things, lots of ways to talk about co-production. I think it's probably easiest to say what it is not, and it is not patient consultation, it's not engagement, and it's not participation. So we think of it as a switch of investigators as leaders of a research team to investigators as facilitators of a research team. And there are lots of ideas around how to co-produce and what best practice might look like. I quite like these principles that are from NIHR's guidance on co-producing a research project. So these are found on their Learning for Involvement webpage, and I think they're worth a look if you're interested in starting out in co-production, because they go through each principle in a lot more detail and give some tips and tricks on how to navigate different scenarios. But I think the idea of excuse me, focusing on principles rather than a strict methodology is great, because for us, co-producing a project looks entirely different depending on the research question and the team that you're working with. So I just wanted to pull apart the sharing of power a little bit more detail, because I think this is quite a big concept, and I think this is the one that is the most challenging for investigators to get their head around, and why co-production might be a little bit intimidating. So I like how this guidance has set it out, that research is jointly owned, but each member has a defined role. And I think there can be a lot of fear around needing to co-produce a project with a big multi-stakeholder team, and that there is kind of a very flat shared decision-making model. But if everybody's coming from different expertise and with different backgrounds, then I think it makes sense that obviously some decisions will be led by different members of the team. So it definitely needs to be an open, transparent conversation, and voices need to be heard across the board, absolutely. But it doesn't necessarily always mean equal decision making. Research being jointly owned, I think the obvious way to think about this is around if you're creating new IP as a research team, a new technology or a new device, then absolutely that research should be jointly owned by the entire team. Particularly in clinical trials, though, you will have defined roles. So you will have someone who is the chief investigator, you will have someone whose organization is legally responsible for delivering that research study. And I think that's a big perceived challenge from a lot of the investigators that we work with, is that everything has to be equal, and that is not always the case and not always appropriate to clinical trials and some types of clinical research. So, of course, we need to include all perspectives and skills. And if we are having these joint open, transparent conversations, then there should be an easy understanding of what's possible, what's not, and why did the decisions that are made, how did we get there? It goes without saying, respect and value everybody's knowledge, reciprocity, so everybody should benefit from being within that team, and the relationships you're building across different stakeholder groups should certainly be maintained throughout the project and thereafter, to be able to continue the trusted relationship you've made with your patient partners. So have a look at that in more guidance in more detail if you are interested in co-producing. There are other groups that kind of ascribe to different methodology, but this is the one that I quite like. So how do we actually do it? And I think, again, from the outset, it's important to define how you're going to co-produce your project. They said it does look different for us with each project, depending on the research question and your team members who are on board and what expertise they might have. So start with open and transparent conversation and agree what you're going to do, agree those roles, and agree how you're going to communicate and stay in touch. We appoint key facilitators. So each project has essentially a manager, and then we have a few key patient partners and a few key clinical partners, for example, and then those people would cascade any further outreach throughout their networks. You might want to consider having a letter of agreement, even though it's very upstream. If you're quite new to working in multi-stakeholder teams, you might feel comfortable having some kind of terms of engagement and expectations about how people will communicate or interact. Certainly, if you're working with industry or working on new IP, then you might want some kind of confidentiality agreements in place, or it might be an organizational requirement. And also try to use the resources and capacity that you've already got. So it is more time consuming to co-produce projects. So try to kind of capitalize on meetings which you might already have scheduled or networks that are already established, and just work to everybody's strengths. Within a clinical trial or some clinical research areas, I think I would personally choose to focus on kind of the high impact areas where co-production can have the most benefit. So identifying the study priorities and design and outcome, certainly writing up your funding application, writing your ethics applications, but once you need to actually conduct your study, if it's a clinical trial, there does need to be a degree of separation between your trial team and the trial conduct. So it might not be appropriate to be as involved in data collection and analysis, whereas some other research types, that might be a great thing. If you're doing qualitative interviews, for example, or focus groups, then there's much more opportunity for involvement throughout. But certainly everyone could come back together for interpretation and report writing and dissemination and engagement that happens at the end of the trial or study. Challenges and barriers are probably fairly obvious. Everyone is stuck for time and capacity, and it can be intimidating knowing how to approach different stakeholders. So how do you even get your team together from the outset? how to approach and who does what, how do you assign different roles. And of course, there's almost always no upstream funding to support involvement activities. And I think we know very well that there's no upstream funding to usually remunerate our patient partners, but there's also no upstream funding to support the investigators or the other research professionals. So everybody typically does this upstream work in their free time around their day jobs. And I think we just need to be, again, have those conversations early about how people can manage that extra workload around what they're doing otherwise. And measuring impact is hard in co-production. So this is slowly changing, but it is still, you know, it is a bit of a question mark about measuring the value and the outputs of how co-producing your project will actually benefit your individual study. And sometimes that can be a perceived barrier to getting investigators and other people on board from the upstream, because they don't necessarily won't have a way of translating that into kind of value for money. So for investigators specifically, we hear that it is co-production and patient-initiated research can be an intimidating thing to support because it is a new way of working for them as well. So I think it's important to remember that it can be challenging to all the stakeholders and not just patient partners. So we typically are asking investigators and researchers to take a bit of a step away from perhaps their own research pathway and focus on something that is maybe not something that they particularly valued before. If we're asking them to step in on a patient-initiated research idea, then there's concerns over whether it's high quality, whether it's an unmet need, what the feasibility is, and the amount of work that might need to go into making a unmet need, turning that into a feasible research idea. Definitely a big issue is organizational challenges and red tape that investigators might have to wade their way through. It's not always easy to connect with research teams that are outside of your organization. And in fact, we had one really challenging occasion where we had received grant funding for a patient-led project, and the investigators were on board, but the host organization could just not agree appropriate contracts with our patient partner, and we had to return the funding. So that was incredibly frustrating, and unfortunately there's no easy solution, but I'm happy to try and talk through any individual challenges if they come up with you. Okay, jumping a little bit to what I do in my day job is as a research lead for the Patient-Led Research Hub. So we are nearly 10 years old now, and we work with UK-based rare disease patient groups to help them develop and deliver their own research ideas. So we help them develop feasible research ideas, so turning those unmet need into something that is ready to be supported by investigators. We help build multi-stakeholder research teams, so we do the hand-holding for those very early collaboration discussions. And then we help the larger team apply for competitive funding applications. So if the project's funded, then we take a step back. We're not involved in study conduct. We return to help another patient group with their proposal. So we try to be a bit of a brokering service that is a step ahead or a step before the existing research support services. Just to show you really quickly what our portfolio looks like, and if anyone's interested in individual studies, I'm very happy to go through. But I think what is interesting here is that a lot comes through the door, but most of them kind of fall at the first hurdle about the patient group needing to be involved. So I think there's more to be done there about getting patient organizations research ready and feeling confident to be able to take forward their own research questions. But the main thing I wanted to pull out was this fact that of our 12 projects that we have co-produced, we were able to secure new funding for 7 of those. So I think that's a great number, because rare disease research is really competitive. So I think we can show that this approach is something that we should be considering more often. And then for smaller projects, we could incorporate with charity funding or investigator funding. So we were still able to take those forward, and only one were we not actually able to get grant funding for. Right, and so one way that we've been trying to explore how we can improve our capacity at the Patient-Led Research Hub and how we can make it easier for patient partners to connect with the research stakeholders that they need to drive new research is this new community-led rare disease research network. So it's great to see some of our patient partners on the call today. This was funded by a 2023 NIHR Public Partnership Grant and co-led by Cambridge Rare Disease Network. And we recruited a brilliant group of about 25 adults from the rare disease community. And we were really interested to know what tools or what they might need to get research ready, I suppose. So how could we make it easier for them to get started within research and connect with the other professional stakeholder groups? So we had contributions from patients around the world, and we did our best to also connect with investigators and other stakeholders to make sure the RDRN would be beneficial to them, but also complement the work that they are already doing within their investigator-led platforms and their PPI networks. So the result is the RDRN, and it is an online networking platform. The overall aim is to really develop and showcase patient priorities, to provide kind of a pathway to help de-risk patient-initiated research ideas, so to kind of de-risk them and get them ready to be taken forward or co-produced with investigators and other teams. But it's also a space for investigators to kind of pitch their ideas and sense check their research plans or their innovations with a very motivated patient community upstream, so well ahead of funding. So hoping that it will kind of be a space to broker these new partnerships and early relationships in a kind of safe, inclusive environment. And as I said, we know the PPI landscape is very crowded, so we're doing our best to make sure we're collaborating and that what we're doing is novel. So what does it actually look like? We just launched in November, so this is our first iteration, and it is still a bit rough around the edges. But it's a free platform. Anyone interested in rare disease research is very welcome to register, and create a profile and tell us a little bit about yourself, what skills and experience you might have, and also what your research interests are. So they can be disease specific or disease agnostic. And we use that information then to kind of match make across members. So if you're looking to team up with someone on a specific research area, then we can put you in touch with other members. Or if you're stuck within your own research journey and you need help with design or statistics or whatever it might be, then we can also introduce you to members who've said they'd be happy to share their expertise in that area. So it is a safe, inclusive networking site. At the moment, there is kind of like a skeleton of resources there. So it's a research journey that takes you through kind of the main stages of developing and designing clinical study. There's not much there. And what is there is currently aimed at patient communities. So there are resources that have been composed by our working group. And we're hoping to develop that in a lot more detail over the next year or two. And you can sign up for a peer mentorship program. So what's next with the RDRN? Our funding ended in December, so we're currently applying for another grant round, which we will really focus on developing that research pathway, both for patient communities, but also for investigators to be better and more confident in co-production and supporting patient-initiated research. In the long term, we'd love this to transition away from grant funding and be its own kind of social venture of some description. But in the immediate, we're really keen to have any and all feedback. So this is a new approach, new method for us. So please have a look if you're interested in rare disease research, sign up, or if you're just interested in learning about new methodologies and co-production, please come along and let us know if it works or if it doesn't and what we could do better. Now is the time to share your thoughts while we're still very early in this process. So there's some contact information. Please, I'd love to hear your thoughts on PLRH or RDRN. And if you are interested in patient-led research, then also please send me an email and I'd be very happy to chat through your projects that you've been working on. Thank you. Stop rambling at you now. And very happy to take any questions whenever.
Thanks, Laura. I didn't detect any rambling at all. I thought that was a really, really clear overview of co-production and the opportunities and challenges that it presents. So that was great. And also in terms of what the Patient-Led Research Hub and RDRN are aiming to achieve and are achieving. Does anybody have a question for Laura? You'll need to raise a digital hand instead of an actual hand. While people are thinking, while you were talking about the way that the projects that you've handled through the Patient-Led Research Hub, how they play out, and you talked about each project having a facilitator, which sounds great, and I guess that gives both parties confidence and that they feel they're being, especially if it's a new thing, a new way of working to them. I imagine really helps them overcome uncertainty at the beginning and get into the process. But that's quite labour intensive, I suppose, isn't it? And I wonder, I don't work within universities. I wonder if you're seeing what the trend is in terms of, for example, the resource available in for PPI support from universities generally. Is that something that's growing, or is that still a challenge to get support directly?
Yeah, I think two things there. I think definitely PPI support is getting better, and there is a lot of resource, at least in Cambridge and the investigators we work with. There are a lot of people and a lot of tools to introduce what PPI is, and there's more PPI professionals embedded in clinical trials units and research organizations, which I think is absolutely brilliant. I guess, in my opinion, most of that focuses on kind of the traditional PPI, the consultation about if an investigator has a project and they're keen to involve patients in public, often as early as possible, which is brilliant. And there is support and professional support or guidance there. What we do is slightly different, and I think co-production for us still is co-producing patient-initiated and patient-led research. So the research ideas that we work on come from the patient communities, and there's less support around that because the expertise we need is to upskill the patient partners and build their confidence in reaching out to investigators. So almost like reverse PPI. We've got the patient community, but we need the other professionals on board too. And that, I think, is where the project management role is really essential, because when we reach out to investigators new to patient-initiated research, I think it is it's just a bit of an unknown. They don't know what they're getting into. They don't know what their role needs to be, how much they need to support, or how much they're expected to do. And quite often the research that we're putting to them might be within their field, but maybe tangentially to what they've been working on. So I think our role is a lot of de-risking, in the sense that we try to just make it as easy as possible to have those early conversations and set the scene about who does what and how we can facilitate a very easy relationship. And I think that's still new. I don't think there's as much support around that. But it is getting better, and at least it's getting more well known, and we're having the discussion now, which I think is really positive.
Yeah, thanks, Laura. And do you see that as one of the challenges because I guess what you're trying to do with Rare Disease Research Network is to increase the capacity of the process, and allow more partnerships, more contacts to be made. But I guess that sort of labor-intensive support is not going to form part of the new model, is it?
I hope that it will help, definitely,
Yeah.
because I think a lot of the time the investigators that we reach out to really love the concept, and they are happy to help. They just don't know how to fit it in. So I think we need to make it as easy as possible for everyone. And the RDRM was mostly born out of the need to expand PLRH capacity and to respond to the need and the desire from the patient community to not need us as a middleman. It should be easier for them to find investigators in their own right. So I think we've got about 230 people on the site already, and I guess we'll just see how it goes. I think people who are online are obviously open-minded to the process and willing to support, and hopefully they'll be happy to take those things on independent of the PLRH. But we do have staff behind the scenes who are trying to manage outreach and do a bit of one-to-one support to make sure that we can do the matchmaking and the early hand-holding if we need to.
Brilliant. Sounds great. And I'm really, really interested and excited to see how that develops. I don't see any hands with any questions. Obviously, if you have questions that occur to you later on, do pop them in the chat. And Laura put up her contact details earlier, and you can come find me if you want to find out more afterwards as well. Thanks ever so much, Laura.
Thank you.
Late query coming in from Tara. Tara's asking, could you say something about
measuring impact
success
so
in
far?
measuring impact?
Great question. Measuring impact of co-production or of RDRN or PLRH or individual proposals.
Tara, please do, if you want to expand, you could either go into chat. Co-production, generally.
Co-production. I think so. We're not really good at measuring the impact of our co-production. I have to be completely honest with you. People who are good is the UCL Co-Production Collective. So I think I would direct you to their platform to have a much more detailed view of the impacts and the benefits of co-production. We see it working well, but I think for us through the PLRH, the reason we've not really sussed out yet how to do it is because we only support the upstream collaboration activities. And so the fact that a research project might not get funded doesn't necessarily mean it's because it was co-produced in the right or the wrong way. It's just rare disease research is incredibly competitive. And if we look at terms of like recruitment and uptake and dissemination of results at the other end, then that's also something that we're not closely involved with. So I think for us, how we internally think about is it successful? It's more things around feedback from our patient partners and investigators and the multi-stakeholder team. Does everyone feel heard and valued? And are they happy with the funding application, for example, that's gone in? Has the research that's been produced really reflect everybody's efforts? And so we know that, or we're confident that what we're doing is successful in that way. But I guess in terms of measuring impact, I don't have a great answer. I will signpost you. Sorry.
I think that makes perfect sense, Laura, the way you describe, the kind of feedback that you do get that seems relevant to what you do. So thank you for that. Lovely. Thanks so much, Laura. We're going to move on now to our next speaker, Allison. And Allison, I know you have some slides as well. Should we see if you can share those?
Yeah, thank you. Hopefully you can all see my slides and hear me okay.
Yeah, there we go.
Lovely. Thanks very much. So I'm going to give you talk you through an example of our experience that came about through a really positive experience with the PLRH and the relationship that we built with them several years ago on a piece of patient-led research that they helped us with. and how that historic relationship helped us to become an enabler to co-production of research project that's been ongoing for some time. So just a little bit of background about who we are and what we represent. So I represent Ring 20 Research and Support, long name. We've been around for 11 years now. We're the only patient group for ring chromosome 20 syndrome, or R20, in the world. So much like these ultra rare diseases, you know, very alone out there. And we're supporting over 130 families worldwide, which is 60% of the reported cases in medical literature. So we're trying to do the best we can for everybody globally, but UK based. And our vision is to promote research, education and continuous support to end undiagnosed and misdiagnosed ring 20 epilepsy. Because ring chromosome 20 syndrome, or ring 20, well, what is it? It's a difficult to treat epilepsy associated with learning and behaviour difficulties, and it presents in a mosaic and a non-mosaic form. I'll talk a little bit about that. That will become relevant in a moment. And interesting fact, ring chromosomes occur in 1 in 30,000 to 50,000 live births, according to the literature. And yet, why only 200 cases in the world? Now, let's put rare diseases into context. And I know all of you probably know this, but, you know, 8,000 plus rare diseases out there, growing all of the time, especially in this age of genomics and finding new diagnoses. And if we look at the rare epilepsies, Epicare talks about 160 plus rare epilepsies. And indeed, there's actually 800 plus pathogenic genes currently identified for epilepsy. So we as Ring 20 are just one little tiny fish in that major ocean, trying to be seen and to be heard with our research wants, ideas and needs for our community. And what are those needs? Well, just like many other of the rare disease groups out there, we've got challenges around diagnostics, around treatment and around care for the individuals living with Ring 20. But we particularly honed in on the diagnostics problem because, do you recall I just mentioned ring chromosomes occur in 1 in 30 to 50,000 live births? So not that ultra nano rare. And ring 20, chromosome 20, rings on chromosome 20 are supposed to be one of the more common rings. So why only 200 cases in the world reported? So there's a big problem around diagnostics. And in this new advanced generation of newer technology and sequencing techniques, we've moved through array CGH, through exome sequencing, and now whole genome sequencing becoming much more mainstream. But actually, these techniques cannot detect a ring chromosome. And that's because the majority of cases of ring 20 syndrome are the example of B in this diagram. There are actually no deletions. And these more laser focused techniques, sequencing techniques that can see genomic changes in more and more greater detail, that creates this explosion in genetic disorder diagnoses, actually are looking for deletions, duplications, things that are missing, and they're not looking for structural changes. So the R59 test, which is what many individuals with a refractory epilepsy will be sent off for through the genomic test directory, won't help us. You've got to go back to old-fashioned karyotyping, which is going out of fashion because we're losing our cytogeneticists and our cytogenetic labs in favour of these newer sequencing techniques. And what makes it even harder is, even if karyotyping is considered, you need to request the clever geneticist needs to ask for 50 to 100 cells to pick up potentially low-level mosaicism, because rings don't occur necessarily in every cell of our body. So solutions to this problem, well, we think we need to raise awareness of how to diagnose ring 20 and also the signs and symptoms of the condition, so clinicians and geneticists know when to make the appropriate test. But longer term, we wanted to find easier ways to diagnose this condition. So this is where the co-production came in, and it all happened and started over 5 years ago now, when I was invited to speak at Rare Summit by our Cambridge Rare Disease Network, CamRare, and I was part of a patient advocacy panel, and I was talking about our experience with ring 20, and I was given an opportunity to present a problem, and I threw in off the cuff into my presentation, we're here at the Wellcome Genome Campus, the home of whole genome sequencing and, you know, the 100,000 Genomes Project, and yet we have a rare disease that you can't diagnose yet. Little did I know that there were members within the audience from Illumina who came straight up to me after the break and accepted the challenge to say, hey, that's a really interesting problem. We'd love to work with you on this. So fast forward a year or so and several conversations, and we agreed to continue to work together to see what we could do. And Unravel was born. That was the project name for making genomic understanding of ring chromosome 20 syndrome possible. And we worked together with Illumina, and we built a two-phased project process. And phase one kicked off, which was an education and awareness program, because our patient community needed to understand that that ring chromosome rather than a linear chromosome, that wasn't the whole problem that we were looking at. The ring is merely a symptom of the problem. We need to find the genomic change that causes that ring, those sticky ends, to stick together so that we can actually identify a target for diagnosis and for better treatments. And we brought together some ring 20 champions, parents, carers, and individuals with the condition themselves from around the world who worked on a regular basis really, really hard to bring an educational program, an awareness program to life on our website and through our social media channels, not only to educate our families and members of the public, but also healthcare professionals as well about this rare condition. And as part of that project, we did a survey across our member families, and we asked them a simple question: what year did you receive your ring 20 diagnosis? We plotted that on the chart that you see before us, and underneath that chart, we actually plotted roughly the advances in the sequencing technologies. And you can directly see a correlation between the advances in those technologies and now what we've seen over the last 10 to 15 years is active diagnostic decline, which goes against the strain of rare disease diagnosis in this genomic era. And as a consequence, the majority of our individuals are now in adult services, and we're seeing fewer and fewer children coming through and being diagnosed. So Illumina wanted to work with us, and they had this fantastic idea that they wanted to undertake a research study, an R&D study, to really look at samples from people with ring chromosomes and look at them through their sequencing technologies in an R&D setting and see if they could find some kind of marker for us. And our patient families, the individuals, were saying, hey, we'll give a blood sample, we'll go tomorrow. Where can we give our blood to make this happen? Research, this is hugely exciting. But there was this brick wall standing between our families and Illumina to make that research happen. And that was ethics, which means that industry can't take blood samples directly from patients, and patients can't directly interact with industry. So this is where we turned to our partners, our previous historic relationships and said, hey, we've got a problem. We as a Ring 20 community didn't want this to be a complete stopping barrier. So we talked to the PLRH, we talked to the Cambridge Rare Disease Network, and we said, we've got this challenge, we've got this brilliant research opportunity. It, you know, really wants to move forward a research idea that we want and need to see how genomics can help us. But how do we get past this? And we talked together and we explored ideas. And what we came up with was talking to the NIH Bioresource, which hosts a repository for samples that can be used by industry, by researchers, to request those samples for appropriate research projects. And through conversations over the process of about 6 months, we actually identified an opportunity to get some blood samples from a small number of people with Ring 20 into their tissue bank, which then allowed Illumina to request access. Now that became an enabler because we have no biobank, there is no repository, and this is going to sound familiar to so many ultra rare disease groups. So this was a game changer for us. And then in February 2022, on Rare Disease Day, we were able to actually announce that the R&D study was actually open for recruitment, and our patient recruitment commenced. We developed also over that co-production and that partnership with Illumina, a wonderful animation video to try and get our families to come forward and give their samples. And you can see our lovely little mascot there, Otzi, that's become a mascot for Ring 20. And excitingly, through that relationship with the Bioresource, we also had, as part of their rare disease cohorts, an opportunity and an approval of a new rare disease cohort for ring chromosomes, which is hugely exciting. And further, working with industry in this way, Illumina enabled us and agreed to host our families conference, only the second conference we've ever had for Ring 20, at their building in Cambridge. You can see our families there. And as part of the conference, where we had presentations and talks from researchers and clinicians with an interest in Ring 20, we also were very lucky to have a genomics presentation and how genomics could be applied to Ring 20 by David Bentley at Illumina at the time. And we had a wonderful lab tour to explain to our families how whole genome sequencing works and how Illumina technology works and could be applied to that, and a really exciting and fun, engaging activity of DNA extraction from strawberries by their training team. So, you know, it opened so many more doors beyond what we were doing. But where are we now? Well, 2.5 years down the line from when that R&D study was announced, we're still looking. These things aren't easy. And if somebody tells me again that ring chromosome structural variants are complex biology, you know, I've heard that so many times. That's not going to stop us. That can't be just because we're not the low-hanging fruit. This is not an impossible thing. It's just difficult and it's hard. And it's made harder. We come back to the fact that it's mosaic. In the majority of cases, you know, many people have normal chromosome 20s in many of the cells in their body, and a normal chromosome and a ring in other cells of their body. And that's what makes it really difficult to pick up with the newer sequencing techniques, because they only typically use a very small number of cells. Sadly, last October, the Bioresource, due to funding constraints, have had to close their rare disease cohorts in favour of other cohorts for recruitment going forward, mental health and BAME communities, to name a couple. So our ring chromosome cohort never really got off the ground, and that's a real sad thing to say for rare diseases generally. And so we're not going to stop looking, because Illumina keep looking, and we're not going to stop because those samples still exist. And we're talking to other genomic companies to just see if there is any opportunity for anyone to be able to answer the question of what is the genomic change in Ring 20. Our families said to us, well, I'm already diagnosed. How's genomics going to help me? And that's a kind of a question that will come through rare disease patient organisations. But finding more people with a diagnosis can help you identify how many people are affected, which is often unknown. We are 1 in a million with Ring 20, or less than 1 in a million actually. And it can help to identify and delineate the prognosis of the condition and how that changes over time. And more people with a diagnosis enables more research and more interest, and can create an increased demand for improved care and treatment. And importantly, if we've got that genomic change, we can then have a druggable target for therapeutic discovery, so better treatments. We've worked with the patient-led research before, but so we believe in the power of patient-led research. And we've then undertaken in the last couple of years a patient-reported impact study with researchers at Newcastle University. And again, our Ring 20 champions, our parents, carers, helped co-produce that because, as an example that Laura had said, what our families did was they enabled patient interviews. So they undertook some of the interviews, so we shared the workload, but importantly, because of our community is global, they did some translations. So we even included families where language was a barrier in terms of English not being a first language. And we're moving forward because we've got £80,000 of patient funding available for a new research study, and we're really keen to find some researchers to help us drive forward understanding in Ring 20. So we at Ring 20 have a research strategy because we believe that every piece of the puzzle brings together a better understanding, and we need to complete that puzzle to really understand Ring chromosome 20 syndrome. And why is Ring 20 an important epilepsy to study? Well, it could be a model for other chromosomal disorders with epilepsy. You know, structural variants are ripe for discovery. There's a lot of focus on monogenic disorders, and our EEG could be a super outcome measure as a biomarker. We can be relatively low cost, and opportunities have the potential to be disease modifying. There's a saturation in monogenic disorders and in monogenic epilepsies. There's a huge interest in epilepsies at the moment with the IGAP and the epilepsy PSP top 10 priorities. And there's a great interest in Ring 20. So we're ripe for change. And we believe success in Ring 20 is success for other epilepsies. So we want to be partners for success. We want to go on co-producing research. And together we believe we can work towards a better future. So I hope that's helpful, and thank you for listening.
Thank you so much, Allison. That was brilliant. Again, I think you set out the sort of technical problems really well, and it's always good to be reminded of the constraints of genomics, the limits of genomics. Because we talk quite a lot about, you know, 20% of rare conditions are not genetic, so we have to not forget those, but actually this is a different but related problem. Does anybody have a question for Allison? Again, I might take chair's privilege while people are thinking. Oh, I was really interested in the ethics problem that you had at first, Allison. Just so I understand it, that's because the proposition was that it was going to be industry in direct contact with individuals just via the patient group, as opposed to via you know, recruiting through a NHS clinic, for example. That was the key stumbling block.
Yeah, it was the fact that we as a patient, yeah, exactly. We as a patient group had this direct relationship with industry, but what ethics says is you need a PI, and you need who controls those samples that industry need to use to undertake their research, or and it may not be just the samples, there's also phenotypic information as well that goes alongside that. You know, genetic test results, for example, the karyotype results would need to be passed on, and that has to be done under the jurisdiction of a PI, and we didn't have a PI. But through the bioresource, we were able to identify a researcher within our community who would put their name to this. They actually didn't have to do anything very much other than put their name to this. And the bioresource, you know, were hugely beneficial to us in allowing us to recruit. I think it was just 9 patients in the end. It was just such a small number, but for us to have a relationship with a biobank and to set that up is really, really challenging and potentially costly, which as a patient group we couldn't afford. So it really sticks up barriers for rare disease groups like ours, for the nano rare diseases that don't have these resources in place. But there is a way through, because we found it. But what was interesting on that journey was there wasn't a document or a pathway or an online resource that we could go to say how we could navigate that problem. We had to talk to all these different people, and even when we were speaking to them, it took 6 months for all of us to work our way through what would be an appropriate solution. So it's interesting that we weren't trying to circumvent protocol, but protocol wasn't defined. And I think that was surprising.
Yeah, it was a really knotty problem, wasn't it? And I guess given the end of current recruitment of further rare disease samples into the bioresource, you would be back at square one if you were starting this now. I guess that might change in the future. I don't know what the noises are around that. Are any of the other sample repositories in the UK, as far as you know, a potential solution to that problem, or are we really looking at that this is basically we're going to be back to that fundamental ethics problem for anyone else trying to do what you've done?
I think that the ethics problem is going to exist. So anybody who has already historically recruited into the bioresource, those individuals can be recalled for future research. So it's not that any individuals for specific rare diseases that do exist there can't be recalled. And Decipher is open for children, and not just with rare conditions, but any child. So I would very much urge rare disease patient groups to look at Decipher and to encourage some of your patient families to have their children sign up to that, to get them recruited within the bioresource, because once you're in the bioresource, you can be potentially recalled for future studies as appropriate to you. But additional recruitment is closed for the foreseeable, and that is, I think, a very sad reflection for rare diseases in the UK. With our rare disease action plan and rare disease framework, it's really closed the door, and could create problems for other groups trying to do something similar to that which we've trying to do, move forward with industry and try and or biotech or pharma. You know, I think it is a big challenge.
I'm just looking, I don't think, oh, someone has a hand up. Tara, go ahead.
Hi, that was really fascinating to hear, Alison. It's kind of following on from what you and Amy were just discussing. I guess you would be in a position to share, maybe through this group or elsewhere, the steps you took. And I don't quite mean the shortcuts to those steps, but now you know what the steps are, you know, they could be shared with other people who, in the position you were in before you navigated this maze. And I was wondering also, because I think that'd be really helpful for other patient groups and support groups. I was also wondering, and I don't know if this came up in your discussions with NIHR, but whether or not these data repositories, whether or not there might be a way to make them more aware of this problematic issue, and if they could agree, you know, it might be individually or it might be across them, a process to because you know, as you were saying, you do need checks and balances, but a process to avoid everybody having to take 6 months to get to the point that it took you to get to. I don't, maybe people would or wouldn't be open to it, but it might be worth exploring.
Yeah, I think it would probably be a great idea to somehow, that if I could somehow write down a quick crib sheet or something at some point to sort of explain to people that might be coming across this problem, sort of some of the steps that you might want to consider, or the things that you need to navigate if you want this sort of research to happen. And yeah, absolutely, as Laura said in the chat, that would be a great resource for RDRN. I think we have a really good relationship with the bioresource, and I think they are very aware of the challenges that the changing criteria for their recruitment has had for the rare disease community. But you know, they've had to make changes due to funding and to priorities that are set. And I think, you know, the priorities seem to be aligned, I guess, with the 10-year plan. You know, mental health is very much high on the agenda, and we do need more research into underrepresented communities such as the BAME communities. But, you know, I would always argue that the rare disease communities are also underrepresented, and that should be a consideration, not an exception. But yeah, very happy to share something as a written resource for us.
And obviously, any messages from you, we're happy to share through our alliance as well. I think we could talk about this for a long time, but I'm just looking at the time that we have, and I think we probably need to move on to the next speaker. Thanks so much, Allison. So our next speaker is Charlotte, who, as I explained, is unfortunately not very well. So I'm hoping that her recorded presentation is going to work for us. Go ahead, Nikita. Thank you.
Hello, everyone. Firstly, I'm very sorry not to be there live today. I hope you can hear me okay. There is an echo in this room, so do bear with me. So Claire and I are going to be talking about some work we've done together, aiming to co-produce resources for rare disease research. And this is nested in and inspired by our work on the mTOR pathways node, which is part of the 14 nodes within Rare Disease Research UK, and I'll briefly introduce that too. So I'm joined here by Claire. Hello, Claire, who is one of the members of our mTOR node advisory panel and also a peer researcher. And I am Charlotte, and I'm leading the patient public involvement and engagement on the mTOR node. And I'm a senior lecturer and researcher in the psychology department at King's College London. So just introducing my section of our part, I'm going to talk through how we work together to identify gaps that are recognised by both the community with lived experience, patient organisations and academics and scientists, and how this led us in to co-develop a project proposal, the steps we went through, and then I'll pass over to Claire to tell you about her experiences. So just to briefly introduce the mTOR pathway diseases node for anyone that is not aware of it. So genetic mutations occurring in a pathway in the body called the mTOR pathway affect processes involved in cell growth and metabolism. And this results in conditions that affect multiple organ systems, although in quite different ways. These encompass 14 known rare diseases, affecting approximately 10,000 individuals in the UK. The mTOR node aims to bring these diseases together for the first time in order to better understand the best approach to diagnosis and treatment opportunities. There are many different components of the mTOR node. There are the kind of networking activities, there are the science projects themselves, but also there is a key part that's PPIE, which I'll be focusing on today. So I'm sure you know what we're talking about with PPIE more generally. So in this work, we're trying to bridge the gap between basic scientists and people with lived experience in order to understand their priorities and the best way that we can share and design our research. In rare disease, generally, and in the mTOR node, there are certain challenges with thinking about how to approach PPIE. So, for example, reaching those with lived experience, given the rare nature, and making sure that we can engage them in the research process. Thinking about the huge diversity of rare diseases and the different experiences that each individual and their family will face over a lifetime. There can be concerns around ethics, privacy and security, and general reduced resource in terms of funding. But with these challenges come big opportunities. Working with the community provides us with unique insight into daily challenges that are faced, and this can help us to design research that meets priorities and ultimately will design and inform patient-centred treatments and interventions for overall improved quality of life. PPIE also empowers people with lived experience of rare disease to be advocates for their conditions, and this will increase awareness of them, which ultimately leads to stronger collaborations and increased drive for funding resources and policy change. Working together in this way ultimately leads to enhanced impact. So our first activity in the mTOR node was to establish the mTOR node patient organisation network. And this is a group of 9 patient organisations, which their logos are just shown down here, who represent individuals with a range of mTOR pathway diseases. We held our initial meeting at the end of 2023, where we talked about challenges and opportunities in this research and how to best establish regular check-ins and a network for these groups. Since then, the organisation network has provided feedback on and circulated advisory panel documents for recruitment, and they've also co-authored an academic article reviewing the mTOR node. Next, we established the mTOR node advisory panel, or MAP. And this is a group of people with lived experience of mTOR pathway related conditions, both patients and caregivers. We held our first meeting in the summer of 2024. In this, we talked about our expectations for this work together, and thought about any training that was required on either side, and what our future goals were. And since then, this group has contributed to a research ethics application in tailoring dissemination resources to make sure they're most accessible, and they were also involved in the academic article as co-authors. And so most recently, we hosted a workshop a few months ago in December. This was a hybrid meeting where we brought together the patient organisation network and the advisory panel. We had 11 representatives from 7 organisations and 4 members of our advisory panel, the MAP. And the goals of this were to understand recent progress in the mTOR node, so to share updates on the science, to improve accessibility of mTOR node research, which was a key outcome from our first advisory panel meeting, and to encourage networking and collaboration across the node more generally. So over here we have some pictures from the day, and down here is the itinerary. In brief, in the morning we had some engagement activities where we updated the group on the research side of things, and also conducted an activity with origami to show our delegates how the mTOR pathway works. And in the afternoon, we had more of an involvement session, which I'll talk a bit more about now. So firstly, we wanted to understand how people with lived experience and people that support people with lived experience might describe these conditions. And this was one of the outcomes from our advisory panel meeting, that it was difficult to understand the language and terminology that we used in all of our documents, for example. So we first asked our delegates to say in their own words, what is the mTOR pathway? And I'll just pick out a few of the general themes here. So there's one on communication, so a way different parts of the cell talk to each other. On growth and development, so a set of instructions in our body that can help different parts of us grow. And on the general impact, having a huge impact on the effective functioning of our bodies. There was also a general theme around the complexity of the mTOR pathway. And so this is something we want to work further on in making our terminology and language more accessible. Next, we asked our delegates to consider how best to describe the condition that they live with or represent, and the impact that it has on their daily lives. And for this, we have both online and in-person whiteboards with post-its. We colour-coded the post-its for people with lived experience of the condition versus patient organisations versus academics. And here again, I'll pick out a few examples. For example, in one of the conditions represented in the mTOR pathway, tuberous sclerosis complex, our delegates were talking about this being overwhelming, a jigsaw puzzle and a roller coaster. And there were also descriptions of how these different conditions might be described. So living with BHD means living with uncertainty about getting kidney cancer and having lung collapses. So we're already starting to pick out the bits that matter the most to people with lived experiences and those that support them. But next, we move from thinking about these individual rare conditions to identifying potential common themes that are shared despite having different presentations and different daily experiences. So we split the large group into smaller groups. We found a number of shared themes that came out of their discussions, which I've highlighted here, and I'll briefly go over. So firstly, living with uncertainty was a major discussion point, not knowing what the future holds for the individual and their family. There was a big discussion about the impact on the family, particularly on siblings being unsung heroes and how this is a gap in support. Isolation with lack of awareness potentially in some parts of the medical community, but also on the back of that, the need for community connection and how this is so helpful in helping families to navigate diagnosis and treatment. There was discussion of the financial and practical burden of these conditions, the need for care coordination across multiple specialties, and a discussion as well on the impact of mental health that requires further support and research. And so we then asked the small groups to reflect on what the mTOR node itself might bring to these common themes. And they talked here about how interesting and valuable it was to hear from other people that do seem to have these shared experiences despite having different individually rare conditions. They discussed how important it is for this research to potentially work towards a cross-condition treatment. And more generally about the importance of collaboration and sharing of resources across communities and patient organisations. So taken together, this workshop showed us just how impactful the lived experience voice is in shaping how we understand rare and complex conditions that will feed into how we design research in the best way. So now I'd like to introduce a new co-production initiative that we are currently working on called Connect. This stands for Co-Produced Networks for navigating rare disease research and care together. And this is based on all of our discussions with the Patient Organisation Network and the Advisory Panel. And we want to take our work so far a step further to create tangible impact by co-producing resources in a systematic and strategic way. This will be shared nationally, internationally, and hopefully drive funding and policy decisions. And this is based on our observations and discussions that disconnected patient communities like those in the mTOR pathways node see the value in collaboration and in sharing of resources, and in understanding that there are common experiences despite having different individually rare conditions. We also want to encourage patient involvement in rare disease research more generally to try and overcome some of the challenges that I discussed earlier. So Connect is a multi-stakeholder collaboration between academic researchers in the mTOR node, between patient organisations that I discussed earlier, peer researchers with lived experience. These are Nicola and Claire, and they are partners that are actively shaping this research proposal, and also artists and engagement specialists helping us to develop a more accessible and experience-led resource that's engaging and can be widely disseminated. So over here we have our core team members that have actively contributed to the design of this work, and this is supported by the wider mTOR node, MAP and Patient Organisation Network, as well as Rare Disease Research UK more generally. This is our proposed framework for Connect with 4 stages. So the first stage is around define, so co-defining working terms for working with our research team, including peer researchers. As I said, we've already shaped the proposal together. The next stage is design. So we want to better capture lived experiences, and also these common themes that I discussed in a kind of participatory way. So we're looking into engaging ways to do this, for example, using participatory photography. We will also be co-developing a national survey to identify gaps and priorities in the mTOR node and rare disease. And we'll take all of this work forward to the refine stage, where we'll hold online and in-person meetings to go over what we found, to whittle down the themes, and then there'll be iterative feedback over a few months to lead into our dissemination phase, which is where we will have produced multimedia format resources, for example, a video resource and a PDF resource that can be shared, that are produced in an accessible way and designed with and for the community. In terms of our overall ethos and drive around this, one of our core priorities in designing Connect is ensuring that co-production is not just inclusive in the theory behind it, but also in the way we're doing it in its practice. And that means thinking about a few things. So from consent and transparency, so making sure we have consent from contributors, access and equity, so considering payment for time, but also carer support and flexible meeting formats. Inclusion, so making sure we engage diverse patient voices, making sure recognition is built into each stage, for example, encouraging co-authorship of academic articles, identifying training needs, and asking peer researchers to be involved in conferences. And also open access, so making sure all of our outputs are openly available to the community and all of the key stakeholders to make sure we broaden our impact overall. And our outputs from this work are, we're aiming to produce, as I mentioned, patient-led handbook and video resource defining mTOR pathway conditions, also producing guidance on how we've conducted this work together to help other researchers embed co-production in rare disease studies and hopefully encourage this way of working. And generally a roadmap for policymakers and funders to better align research priorities with real-world patient needs, and this will be our kind of longer-term plan as well. So that's an introduction to what we've been doing in the mTOR node and what we're planning on doing with our new co-production initiative, Connect, which is designed with and for patients and families, not just about them. So we're hoping to develop sustainable, co-created resources for rare disease communities. And I'd like to finish by saying co-production is an ongoing process and not an outcome. So in this work, we really want to ensure that we have continuous communication and dialogue and that decisions are made together. So on that note, I'd like to pass over to our fantastic co-lead of this project and peer researcher, Claire. Thank you very much for listening.
Good to you, Claire.
Oh, we can't hear you now, Claire. We did hear you when you first joined the call. I'll bring you off mute.
Can you hear me now?
Perfectly. Thank you.
Lovely. Okay. I feel it's rather a grand title to be called a peer researcher at the moment. We're at the early stages, so bear with me. I'm learning this process very much. So I have a lot to learn. Charlotte asked me to have a think about a few reasons why co-production actually matters, and obviously the first of those important aspects is why I decided to be involved. I think it's very difficult when you are thrown into a situation that you weren't expecting when you had a child. We had no idea that our son would be impacted by a rare disease. We hadn't heard of it. So there was no preparing us. So we were thrown in literally at the deep end, knowing nothing about tuberous sclerosis in my son's case until he was 9 weeks old, when he started having a relatively significant seizure activity that we did not know what it was to start with. So it's been a very steep learning curve, and one that's very difficult because it's such a complicated condition. So it is obviously multi-organ, and can and potentially does impact many organs in the body. In my child, particularly the brain, and the kidneys are impacted. The skin was impacted for a short period, but that's treatable. So I had to learn a lot about something that was definitely at my comfort zone, but also academically difficult, but also emotionally difficult, because we were struggling with the seizures. Seizure control was difficult actually for many years. I learned a lot about managing seizures and working with doctors, which I became the feeling that it was very much a partnership between what I knew of my child and what was normal for him, and obviously the medical expertise of the doctors every time we were admitted into A&E, resus, and then very often paediatric intensive care. So I already saw partnership as a really important aspect of my son's care. Then I started to hear through the Tuberous Sclerosis Association of various research projects, and I started to think maybe that would be helpful, both for me academically, but also a feeling of purpose that I might have, where you feel very much out of control and unable to support your child and your family when you are going through significant issues. So partnership became a key word in my vocabulary, really. And when I saw King's College doing a research project on epilepsy a number of years ago, I decided I'd get involved, obviously as a lived experience participant. And I found it really helpful to meet other people that had similar experiences as carers. And that was an extremely useful project for me personally. So then when this opportunity came up, I kind of jumped at it. I didn't really think much about it and just thought, yeah, this is something that I can really maybe add some value to. Because often, although I feel I've had very good relationships with the doctors that my son's been supported by, you are removed, you go in, you come out again, that there is a remove there, whereas this would be a more ongoing project, and I could hopefully maybe influence a little in the areas that are of key importance to us. So I found it invaluable to be involved, both because of my son and my family. I have a daughter as well who is not impacted by TS, but is significantly impacted in her lifestyle, in every way. So Charlotte mentioning siblings, it is absolutely key. They're not forgotten, but there's not the resources aren't really out there for siblings. It's difficult to gain support. And I think also there are many organisations involved in supporting in various ways, and you can get a little bit bogged down with all of them, and you can't tap into all of them. So I kind of feel I've had to very much pick out organisations that I feel would be most beneficial for us. Obviously, the TSA is a significant one for us. But I've tapped into other organisations and would stay in touch with them. For example, the Daisy Garland, who are really helpful in terms of epilepsy support, and a local children's hospice near where we live. They provide some emotional support. They also provide some caring support. So I'm keeping my involvement limited as much as I can, just purely because of manageability. So this particular project is going to add a huge amount of learning for me at a stage where I thought my learning is probably mostly over, but it's absolutely not. Research isn't something I have been involved in, particularly in terms of co-leading. I have an MPhil, but I did that 30 years ago, and it was in social anthropology, so literature pretty much was what I was using rather than any sort of heavy research methods. So this is completely new to me, and I'm really looking forward to the challenges and the opportunities it brings to me personally, but also maybe those opportunities it might bring to my children going forward, and how it might potentially shift our lives a little. I think the importance of co-production, more generally, not specifically just for me, is having that different dimension to the research. It can come across sometimes as a lay person that it's one-dimensional. It's focused on the researcher and what they feel are important key issues. This is a massive shift, really, and such a positive one, to have the dimensions broadened and have more of them, because we all have a voice that is useful. My son is non-verbal, so he doesn't have his own voice. So as you can gather, I'm quite happy to speak for him. Others with TS or mTOR pathway conditions are more able to speak for themselves. So it's recognizing those different voices, and this project is absolutely doing that. In terms of things like impact, I'm not sure yet. We are at the early stages. It would be lovely to talk again once we've completed significant parts of this project, so that we can see where impact has been made. right now. I think it's a really interesting and important point that has come up with other presentations, that impact can be challenging to the impact can be challenging to identify. So yes, I look forward to seeing what happens with this particular project. I do feel an incredible sense of privilege to be involved with people like Charlotte, who are leading this project so effectively, and I'm very grateful. I know I don't have to feel grateful, but I feel very grateful that I've been given an opportunity to make a difference, which is really all a parent wants for their child, and especially when they're so impacted by a serious medical or complex medical condition. I think that's all I might like to say for the minute.
Thank you so much, Claire. Really, it's very powerful, I think, to hear you speak about your personal experience in co-production, both in terms of how you feel you're gaining from it personally, but your thoughts around the wider impact and what that might look like as well. We are actually out of time, so we don't have time for questions. I'm sorry about that. If people do have any questions for Claire or for Charlotte, then please do come through me. Nikita, could you put up the final slide with the QR code? So I'll just take 10 seconds to say, if you can fill out the feedback form to give us feedback on the webinar today, that would be great. The feedback form does include the opportunity for you to suggest other topics for further webinars, so that would be fantastic to hear. So it just remains for me to say again, thank you to all of our speakers, those here in person and those not. I think it's been a really lovely and varied and really interesting session today. As I said, we're recording it, and the recording will be circulated and it'll be made available on the Rare Disease Research UK website. Thanks, Nikita and Anna, for your technical support, which has been very, very important today, even more than usual. There's been lots of stuff going on in the background, so thank you both. And thanks everybody for joining today. I hope you enjoyed it. Thank you very much. Bye-bye.